Ryan Stanton here with ACEP Frontline, joined today by Dr. Juan Gallego. Juan is the medical director and department chief at one of the largest and busiest emergency departments in the state of Florida at BayCare. We actually met down that direction in the past. He's also core faculty member for the BayCare EM residency program and a practicing emergency medicine attending for almost 20 years now. A quick note that Pfizer is sponsoring today's podcast, so appreciate their support. Dr. Gallego has been engaged by Pfizer to share his personal and professional experience related to the population health improvement initiatives within his respective institutions, which may not necessarily reflect the views of Pfizer. So Juan, thanks so much for joining us here on the podcast. I'm really excited to learn about what you all are doing down there with your BayCare teammates and recently implemented to help standardize the care for patients presenting to the ED with headache. An incredibly common presentation for us in emergency medicine. ACEP understands this as well. We've put together a point of care tool to support this with our emergency physicians, so we'll have access to that as well. So first of all, let's just learn a little bit more about why, how, and what you did before sharing more specifics around the project that was going on. What did you and your health system leadership prioritize, taking a standard approach to the migraine treatment and treatment in the ED? And then where did you see some of the problems and challenges?
Yeah, so great. So first of all, thank you, Ryan, for having me. It's a real pleasure to be on your podcast. I'm a big fan, trying to suppress the giddiness of being here with you. So just to give a little context, so my hospital, St. Joseph's Hospital in Tampa, we're a very busy shop, like you mentioned, about 120,000 ED visits a year. And we're the hub of the sort of hub and spoke model in BayCare. So BayCare's 16 hospital system, so there's 15 spokes really. We're the hub of those, and this really came to fruition because Dr. Paul Lewis, who was the director of evidence-based medicine at the time, so we're talking about a year and a half ago or a couple of years ago, almost now. He was reviewing local data and seeing that there was quite a bit of a burden on the healthcare system when it comes to migraine headaches, which, no real surprise there, right? Like you mentioned, it's a common diagnosis that we see in the ED, or presentation, I should say, the seventh most common chief complaint, and second most common cause of disability in this country as well. So, and what he found was there was a lot of variability when it came to the workups of these patients, the evaluations of patients, imaging done, not done, the treatments, all this kind of stuff. So he approached myself and my partner in crime, Dr. David Ball, who's in charge, CMO of ambulatory care, and we've created a number of pathways already for our system. So we looked at it and said, yeah, there's definitely some opportunity here to improve what we're doing for this specific patient population. So that's kind of how it started.
I've always been a fan of kind of some of the standardized, especially with these pain complaints, just simply because of the consistency for the practitioners as well as for the patients. And how did you go about putting together, assembling that team to support you? Because we know that everything in emergency medicine is about the team and not having one single person doing a standardized program, but an entire team doing this. And what were their roles in this program?
Yeah, so in addition to being a medical director at my shop, I'm also chair of the BayCare ED Clinical Pathways Committee. And this is a committee that meets monthly and is comprised of all the medical directors from the system. So we meet every month, and what we do is, again, kind of review best practice guidelines for different diagnoses, try to develop power plans and standardize the care. And we'd already done this a few times. So at this time, low risk chest pain, we made one for that based on the heart score. As a risk stratification tool, we made one with AFib using the ACEP clinical kind of recommendations for AFib, DVT. So we'd already had the framework. We'd already created a number of power plans already. So creating something for headaches was definitely within our wheelhouse and capability. So as the chair, I did my research, communicating with our neurologist colleagues, looking at, like you mentioned, the ACEP migraine POC tool, the ACEP clinical policy for headache, up to date. I mean, all these different kind of things to see what's the best way to kind of approach this, and creating algorithms to kind of really give our physicians, our clinicians rather, the support they needed to approach these patients, whether it's the initial assessment of the patient with a undifferentiated headache, or how we're going to manage the primary headaches that once we've kind of looked at that. So that big part of the team was, of course, the medical directors. The other part of the team, of course, is IT. To be able to do this, you need really solid IT folks that are going to help you kind of incorporate this into the EMR. And our local Pfizer team was really helpful too. Ryan and Amanda helping out with providing, not just literature, but a lot of provider education, patient education, in bringing in their sort of insight, because they've done a few things with other facilities as well. So those were like really the three pillars of the team that helped kind of move this in the direction that we needed.
In my role with ACEP, what I really love to hear there, this is a emergency medicine driven initiative with the collaboration with the appropriate stakeholders, but really driven by and for the emergency physicians and our emergency patients. But like anything else, as a physician, we, hate two things. We hate change and we hate the way things are. But anytime you initiate change, that's going to be a challenge. And, just that analogy to the elephant, how to eat an elephant one bite at a time. This is not something where you come in and push the entire elephant into the room at the same time. So what are some of those key early steps that your team decided to take to get the ball rolling?
Yeah, so we already had a ED power plan in place, but it was done actually a few years back, that before my time, and it really needed a makeover. So there was that, and again, after reviewing a lot of the literature, but historically there's always been that sort of popular belief that migraine headaches were due to pretty much 100% vascular etiology, right? But now that there's a lot more information out there, and it really shows that this is the major player with the pathophys behind migraine headaches is the sort of the trigeminal vascular system, and CGRP, the calcitonin gene-related peptides. These are a fundamental protein in the sensory pathway with the head and the neck, and really the transmission of pain. And basically, as we all know, there's been really a significant impact with regards to migraine treatment over the last few years with CGRP inhibitors. So creating algorithms, like we said, ways to evaluate the patient that was presenting with an undifferentiated headache. Another algorithm that once we were kind of quite certain that this was a primary headache, how we're going to treat that patient. We used a migraine screener, sort of an EBM little clinical tool, that we could import to the EMR and to our note, actually using a dot phrase. So we'll talk about that in a little bit. But yeah, a lot of enhancements that needed to be done with the current headache power plan that we had, that lacked a lot of what was happening in real time, and now with all the research that's been done in this space over the last several years.
And as any good emergency physician, when you're invited to show and tell, you brought us some screenshots to kind of walk us through it for those that are listening on the audio side. We'll have these available, but this is one that's going to be a video podcast as well. And so you can check out the pathways there, some things to talk about. And let's really dive into that, kind of walk us through the pathway and how it's, as well as how it's kind of incorporated into the workflow, walk through the algorithm, kind of get us up to speed on what I can expect if I come into a headache to your department.
Yeah, so starting from the top, again, this is a non-traumatic headache, right? Patients presenting with headache that's not undifferentiated, not due to falls or any kind of trauma. And the first thing we're going to do as an ER, our physicians, is rule out the bad stuff, right? 90% of headaches, as we know, are benign, really. About 10% are serious causes, and about 2% are life-threatening causes. So I think as ER physicians, we do a great job really looking at these patients and kind of weeding out the serious and life-threatening causes of headaches, or subarachnoid hemorrhages, meningitis, carbon monoxide poisoning, preeclampsia, all these stuff. It's a long list, but we do a great job, I think, kind of ruling these things out. And then, as you go down the algorithm, once you've sort of ruled out these secondary causes or the badness, as Mel Herbert likes to call it, we ask ourselves, is this a primary headache? And then if it is a primary headache, can we differentiate it, right? There's a lot of sort of classic clinical symptoms of your primary headaches of tension, cluster, migraines, things like that. But there is some overlap too. So sometimes it's a little difficult with somebody who has not yet been diagnosed with a primary headache. So that's where we sort of implemented the use of that ID migraine screener. And it's basically, there's a number of little clinical decision tools for migraine identification. We like this one because it was simple, right? It was like 3 questions. It has decent specificity. The first question was, have you had a headache that's been sort of impairing your daily activities for a day or more over the last 90 days or so? Do you feel nauseated with your headache? And is there light sensitivity? So pretty simple questions. And if you say yes to two or more of those questions, and again, pretty high specificity that it's a migraine, but even better sensitivity if you say no to all three, that it's probably not a migraine. At which point you would say, well, is this a tension? Is it a cluster? Or do I have to re-examine and determine if this is a secondary headache? But once you kind of honed in that this is a primary headache, then we created a whole other algorithm for the treatment of that headache. And you can see that I like that little excerpt that had the power plan that we've created have a lot of this educational statements and things like that within them. So if I see a patient with a non-specific headache and I engage the power plan, open the power plan, then it's all laid out there for me. I can access the algorithms like you're seeing right here. It'll just in real time, just click it and it opens up. And then I also have a lot of like clinical direction as far as how to appropriately manage these patients. And then again, this algorithm in particular is the sort of starting point. And then once you decided it's a primary headache, then we go to the next algorithm and kind of go down that, which is you see here. So left side, you have the tension headaches. The right side, you have cluster headaches. In the middle, we have our migraines. So again, we designed this based on a lot of the recommendations that we went over. And as you can see, so the previous headache pathway had Fioricet in it. It had opioids in it and stuff like that. So we removed those medications because, of course, those are level A recommendations according to the ACEP headache clinical policy. So we removed those medications from the headaches in particularly, and we also added discharge recommendations for the CGRP inhibitors as well, which according to the March 2024 updated guidelines from American Headache Society, that these are now first-line medications for preventative treatment for migraine headaches. So we did all these updates as well. For really the goal to provide our patients with better care and positive outcomes. In which case, from there on out, we would again have, as you see at the bottom, having them follow up with the whether it's primary care or even neurology, so that we can sort of close the loop and have them follow up with them as an outpatient. So that's the algorithms in a nutshell, if you will.
Thanks. I appreciate you walking us through the algorithm itself. But like a good emergency physician, I also want to look at the challenges that we're going to be facing. So with that said, what are some of the challenges or obstacles that you had to overcome to implement the pathway?
Yes, I think you kind of alluded to some of those previously, right? You have your folks who have been, doing what they do for several years, right? And so you have your folks, your physicians and clinicians that adopt pretty well and they do things right away. And then you have your slow adopters, right? The ones that are kind of like, well, I've been giving these patients Fioricet for the last several years. They're doing just fine, right? So it takes a little time, and that's all about education, communication, and then the clinical support too, right? They're a lot more likely to kind of be on board when it's so easy to access the clinical algorithms and pathways and stuff like that, and to have it within the EMR to help them out with. So those are those things. Those were definitely I'd say a small hurdle. The biggest hurdle probably involves IT, just simply because their bandwidth, and we're a big hospital system, and there's multiple service lines that are trying to engage them and get their support to kind of create things within the EMR. But honestly, BayCare leadership, big support for us. They have really given myself and Dr. Ball, free reign when it comes to creating what we think are the best power plans for, and depending on whatever diagnosis we think is appropriate for our system, for our patients to really, help improve the care. So yeah, the biggest hurdles I would say probably, like you said, is getting physicians on board, especially the ones that have been doing, working for a long time, and sometimes it's a little tough to teach old dogs new tricks, and then the IT team.
So that's no shocker there that the practitioner side can sometimes be the hardest challenge, and especially as you mentioned, the old dogs and getting those new tricks involved. So what was your approach to engaging these other practitioners to increase their knowledge and kind of buy in with utilization of the pathway?
So the key really is engaging those medical directors, but like I said, we've got a pretty solid plan with that already because they're a part of our ED Clinical Pathways Committee. So because of that, we're already engaging them. They're giving feedback. They're helping us develop these pathways, as we're going on. So just by having them involved with that, there's already sort of a vested interest on their end to sort of make this successful, right? So they're engaging their providers, spreading the education and doing all that for their respective facilities. And again, that's really important and paramount when it comes to trying to change something and really encouraging other people to utilize the pathway. So again, it's been pretty smooth, I think, now, especially because we created multiple power plans in the past, that we have this sort of streamlined kind of approach. But getting the medical directors involved is key for sure.
And it kind of bounced off the idea of great work. Okay, now what? The next steps. So now that you've got this pathway in place throughout the system, what's the next step? What's on the horizon?
So yeah, this is where the real work starts, right? Yeah, so there's definitely a lot more to do. One of the things we're doing is so one of our EM residents is actually using this as a QI project, looking at pre-implementation, post-implementation, patient outcomes. We're creating a dashboard to help with that, follow the metrics and see how we can really make sure that we're improving the patient care for this. We're using, the smart phrases from ACEP, when it comes to that transition to care and discharge processes to provide patients with the education that they need to hopefully prevent bounce backs and whatnot. And part of that is we created a zone tool looking at, for the patients so that we can say, hey, where's the most appropriate place for you to go? Is it urgent care? Is it primary care? Is it to us? Is it, so depending on what the headache is and what they're experiencing, and engaging the leadership from primary care and urgent care from BayCare as a whole to help them standardize care, know that what we're doing from the ER, so that the right hand knows what the left is doing, and making sure we're all on the same page.
And there's always that idea in the vein of it's not always about the destination, it's about the journey itself. So you've been through the journey now. From your experience with this work, are there other important things that you kind of take home messages that you want to share with others listening to the podcast that are must-haves to really successfully implementing a similar type process within their ED or health system?
Yeah, definitely. For our EM colleagues that are listening, I think if you look at your own local data, right, make sure see if there's opportunities there, see if there are concerning trends that you want to address, because if there are, then obviously, engaging the leadership from the hospital, engaging your medical directors, taking a look at there's a lot of resources out there, and then that should be really the catalyst that if there is something that you see that could improve as far as from the provider perspective, especially with migraines, right? A lot of migraines go undiagnosed or misdiagnosed. So there's, most of the time, if you look, I think that there's going to be some opportunity there. And in doing so, you're going to, it's going to be a benefit for your patients, for your clinicians and the hospital system as a whole. So definitely a win to kind of take a look at your local data and see if there's opportunity there.
Migraine care was the tip of the spear of managing and addressing the opioid epidemic, where we finally said we're going to do something evidence-based, and this is a perfect diagnosis because we know if we do it the way we used to do it and not evidence-based, it makes them worse, more frequent, and less likely to be successful. Not to mention the other risks associated with it. So for me, the migraine treatment has always been my big tee-off for any type of alternative to opioids and evidence-based pain management regimens. Talking with Dr. Juan Gallego, appreciate everything and thanks for the expertise and kind of walking through the process. And as for everybody else out there, thanks for tuning in, listening, joining us today. Hopefully this can help with your processes in your emergency department and within your system. If you want to learn more about this topic, please scan the QR code, or you can visit www.pfi.sr/migraine ACEP POC tool. So migraine ACEP POC tool, all one word there after the slash, to access more information on resource for implementation. And until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.